Okay, so we'll move on to treatment. Sorry for the bad news, Alex. It's been 11 years, still no disclosures. All right, so we'll review some general treatment recommendations, and we'll talk about renal FMD, specific cases. We'll show you some angiogram examples, carotid FMD, and then some future directions, one of which is the hormone question. And you've seen this slide already once, and this is to emphasize the value of having a multidisciplinary team, right? At Emory and other centers, we have multiple physicians who have the experience and the expertise to provide you with this subspecialty care whenever a problem arises, and they're comfortable. It needs to be high volume, and we're not the only one who has a multidisciplinary team like this, but this is really important in terms of having that experience and expertise to provide you with the care that you need, and we're able to communicate and come up with plans for you and coordinate that care, and hopefully that results in good outcomes. So general management recommendations, and you've heard a lot of these before if you've done some of the research or talked to one of us in clinic, avoiding neck manipulation, right? So chiropractors, deep tissue massage, roller coasters, heavy lifting, greater than 30 pounds for a woman, 50 pounds for a man approximately, to avoid straining on those fragile arteries, right, particularly in the neck area. Avoiding tobacco, you've heard about this association with tobacco. Hormones, generally exogenous hormones can increase your risk for cardiovascular events. Stimulants as well, so Sudafed, ADHD medication, some recreational drugs, all those can put stress on your blood vessels. We don't have any information on statins, positive or negative, so generally not indicated for FMD. Antiplatelet therapy, that's your aspirin, and you've heard why we use aspirin is to prevent those little blood clots from forming in the beaded areas, so that doesn't cause a thromboembolic event. Blood pressure medications and revascularization, which is when you open up the artery with a wire and a balloon. And I'm going to show you some example pictures of that. It's rare to require revascularization, but we'll do that when indicated. And usually the most common indication for that is resistant hypertension or high blood pressure when you have narrowing of the renal artery. And we recommend the CT angiogram or the MR angiogram of the brain to pelvis to look for which vascular beds are involved, and are there any incidental occult aneurysms or dissections in any of these vascular beds. So specifically to renal artery FMD, revascularization, that's when you open up the artery. Usually that's for resistant hypertension. Your blood pressure is not controlled despite blood pressure medications. Less commonly for things like tears and aneurysms, but usually it's resistant hypertension. We try to avoid stenting because it's usually not necessary, and that metal in the stent can damage the fragile blood vessel. And good news is it usually cures the blood pressure, defined by coming off all your blood pressure medicines over 50% of the time, and over 80% of the time you're able to reduce your blood pressure medicines. And we historically have done surgeries for this, but we're able to avoid surgeries now because of our advanced endovascular techniques. But if you have complex anatomy, aneurysm, or dissection, sometimes we consider surgery. Okay, and how effective is it? Like I said, cured over 50% of the time, improved over 80% of the time. Most recurrent disease is usually not that it's coming back, like there was a question about progression, but it's that those webs maybe weren't adequately stretched out or separated during that initial angioplasty. And the stent isn't really necessary. Stents are designed to prevent what we call restenosis. You don't get too much restenosis, renal artery FMD, as opposed to atherosclerosis, the traditional type. So angioplasty for FMD is more durable at a younger age. And so this graphic really illustrates that as you get older, it's more likely that the hypertension is caused by something other than your FMD, like essential hypertension or something else secondary. So the people that tend to benefit are closer to 20 to 30 years old, and that benefit may tend to decline over time because the blood pressure is caused by something else. So we're very mindful of that. Okay, and then how do we monitor that revascularization after your procedure? We usually do it with that renal duplex ultrasound, okay? Rarely we see that's residual stenosis, and then, like I said, that's usually maybe an inadequate initial treatment, but we'll do that duplexes in 1 month to get a new baseline, in 6 months for a few years, and then yearly thereafter, and a lot of you have had those procedures with us. Okay, now we're gonna go over a few example cases now that you have some of the background and foundation, okay? 43-year-old woman presents to clinic with severe hypertension, high blood pressure, and headaches. She does smoke, and now her blood pressure is over 160 despite 2 medications. So we were concerned about some sort of resistant hypertension that could have been renal artery stenosis, so we did that renal duplex ultrasound. And here's what the ultrasound looks like, okay? In the middle image here, you again see that tortuosity, the curve here, and that swirling of the color. You see the blue and the red, and again, that's that white water in a river, that turbulent flow example that you heard about earlier. Elevated velocities, and then distal in the renal artery, you see this dilatation with some swirling in it. That's probably an aneurysm. That's what an aneurysm looks like on color Doppler with renal ultrasound. And sometimes we review these in clinic so you can appreciate what we're looking at. So because of that, an angiogram was performed with the catheter, okay, and this is the right renal artery. And what do you see here? Normal or abnormal? Abnormal. Good. And do you agree you see that multifocal beating, that irregularity throughout the right renal artery? And sorry, it won't play again. Distally, you could see, there we go. Distally, you could see that aneurysm that we saw right here. There's the aneurysm, and this is irregularity, that string of pearls or string of beads appearance. Diagnostic for multifocal FMD. And then there's this ratio off to the side. That's the pressure distally compared with the pressure proximally. It's PD to PA ratio. So the way we assess for a hemodynamically significant stenosis is we cross that wire all the way down the renal artery, and we measure the pressure at the end of the artery and compare it to the proximal artery. And if there wasn't a blockage, that ratio would be 1, right? It'd be the same pressure. But if there's a drop in the pressure throughout that renal artery, there's a pressure gradient, and that means there's a hemodynamically significant stenosis or blockage, and we use a ratio of less than 0.9 as positive or abnormal. So there's a flow limiting stenosis here. Okay. Okay, and there's this crossing with the wire, and what we do after we cross that wire, hopefully you can see it here, we inflate a balloon, and it really stretches out those webs to open up the kidney artery. And you see a good angiographic result. Okay, you see it starting to open up, but that ratio is still less than 0.9. So you always want to get a post-procedure gradient to prove that you had an adequate result. And it's still less than 0.9. That means we need to inflate the balloon again. And we do that, and now the pressure ratio is 0.98. So adequate treatment response, normal blood flow throughout the renal artery. You still can appreciate some of the irregularity, but this patient's blood pressure should be improved based on that improved blood flow. And on follow-up, dramatic reduction in blood pressure, only on 1 medication now, headaches improved, and on the renal duplex ultrasound, we have this normal velocity. So that's a typical approach to renal artery FMD when it's causing resistant hypertension, okay? You also heard about aneurysms. So this is an example of a renal artery aneurysm. This patient had multifocal FMD here in the mid-renal artery, and this artery is a little unique because the beating in this case is smaller than the reference vessel. Usually it's bigger, the outpouchings. This one it's smaller. So this is a more rare type of FMD called paramedial FMD. And so that's rare, but this is associated with a saccular aneurysm or outpouching. And if these grow too much, it's like blowing up a balloon too much, and you could be left with a problem, which is it bursts or it ruptures, okay? And to prevent that, if it reaches a certain threshold, it needs to be treated, and it's about 2 centimeters for smaller size arteries in your abdomen. This is an example of what it looks like on the CAT scan, right here. And that can be treated either surgically or now with a stent, and this is called a covered stent. So what you do is you, again, cross that lesion or aneurysm with a wire, and you deploy the stent, and it covers the aneurysm, so blood flow can't get into it, so it won't expand anymore. Okay, so it's just going to clot off and go away and not cause any problems, hopefully. So that's how we treat a renal or a visceral artery aneurysm. Does that make sense? Okay. One more case. This is a 52-year-old woman who was referred to us for evaluation of FMD, and she had that diagnosis since age 29, and she initially presented with her iliac artery aneurysm rupture. That's where your arteries branch off around your belly button and go to each leg. So your right iliac artery, that had ruptured, and she had to have it emergently repaired surgically. And at the time, they also repaired the left iliac artery, and now she's fast forward seeing us over 20 years later. She didn't have any other symptoms such as hypermobility or tissue abnormality suggestive of a connective tissue disease. Her mother had diagnosis of FMD and unfortunately passed away at age 52 from a brain aneurysm. The patient had had 2 uncomplicated vaginal deliveries, and on exam, the only thing we really noticed was that bruit or that whooshing sound in her right groin area. She didn't have any hypermobile features on exam as well. And this is impressive. We still have the histopathology report from 1996 from when she had the surgery. Remember when Dr. Vakili told we used to have a histologic criteria, and we called this medial involvement, and now we use the term multifocal FMD. So she has a histologic diagnosis of FMD from 1996, which is rare. We usually don't have to do these surgeries these days because of our endovascular techniques. And for surveillance, we did the CAT scan. This is what the CAT scan looks like. This is her celiac artery, her superior mesenteric artery. They're the ones that go to the intestines. And here are the left and the right iliac arteries, respectively. And if you can see from where you're sitting, they are beaded, and they have little tiny aneurysms and even a small dissection on the right. So multiple vascular beds involved. Because of that clinical presentation of the aneurysm rupture and multiple vascular bed involvement in the family history, we are concerned something else might be going on, so something perhaps genetic that could have been contributing. So we did genetic testing, and the variant was COL3A1. Anyone know what that gene is associated with? That's vascular Ehlers-Danlos, correct. So this patient has a genetic diagnosis of vascular Ehlers-Danlos and a histologic diagnosis of fibromuscular dysplasia. So that would be very rare, very interesting. That's why we're talking about it. But the take-home point is that if you have multiple aneurysms and dissections and multiple vascular beds, family history, maybe some hypermobility, something else suggestive of something systemic going on, that's when we consider genetic testing. We generally don't recommend genetic testing for fibromuscular dysplasia, and the yield for this is usually less than 3%. So, but it is on our radar, and that's why we ask you all these questions in clinic. So perhaps in the future, we'll have some genetic testing for FMD and more of these conditions. But if there's some signal there based on your history and your physical exam, then we will send that genetic panel to make sure. To touch on carotids briefly, in terms of revascularization or procedures that you might need, it's very rare to require a carotid revascularization. Class 3 means it's not indicated, meaning you don't need it. So if you have a stenosis, regardless of how severe, it's not going to help you, and we generally don't recommend it. Those carotid arteries, again, are going to be fragile. We don't need to put a wire and a balloon or a stent in that artery. It's generally not going to cause a problem. And someone already asked, is this progressive? And it's generally not progressive. Okay, Class 2A means it's reasonable to open up that artery if it's causing recurrent symptoms, something neurologic or like a mini stroke or a stroke, something like that. So often reserved for recurrent symptoms. We do the balloon angioplasty, try to avoid the stent like I already mentioned. And IVUS is just a fancy word for intravascular ultrasound to evaluate the blockage and stenosis. Pseudoaneurysm, you're going to have a whole talk on intracranial aneurysms and dissections later on with Dr. Nahab, but you might see these on some of your own imaging reports. Pseudoaneurysms are usually the result of a prior dissection or tear in that artery that's now healing, and there's a tiny little outpouching. They tend to remain stable over time. They tend to not grow. And because of that, they usually don't require any revascularization or repair. Okay, but if they do expand, or if they're causing some symptoms, especially if it's neurologic, we do consider it, and that could be something like a covered stent, like I already showed you in the renal artery, or other surgical options. That would be the exception. Usually pseudoaneurysms remain stable over time, but we keep an eye on them. So, future directions, we already touched on the hormone question, so that was really good. Understanding the genetics, we've talked about that a lot. We have a lot of work to do there. And it's important with all that information to try to figure out and help you all who's at risk for having some of these complications. Most fibromuscular dysplasia patients don't have events such as dissections and aneurysms, but it'd be helpful to try to predict who is at higher risk based on clinical features or genetic features, so we can be more aggressive with treatment and surveillance. The role of aspirin, antihypertensives, and other novel therapies that we have yet to discover. Okay, thank you so much for your time.